Welcome, everyone. We're going to give folks just a minute to get in and hooked up and settled, and then we are going to begin. As you're joining us, feel free to put who you are, where you're from in the chat. We like keeping the chat active as we're listening and watching presentations, so feel free to pull that up and use that throughout the webinar. Okay, well, welcome to the ROSC webinar series. This is session 2, Empowering Communities to Address America's Mental Health and Substance Use Needs. Today's presentation is brought to you by the Great Lakes ATTC and SAMHSA. The Great Lakes ATTC is funded through cooperative agreements with SAMHSA. The opinions expressed in today's webinar are those of the speakers and do not necessarily represent the official position of SAMHSA or DHHS. And we like to remind everyone it's very important that we use good language because language matters and words have power. So thank you once again for joining us today. If anyone experiences any technical issues related to Zoom or has any questions about the production of the webinar, please feel free to reach out to me, Christina Spambauer. I'm identified as tech support. If you look at the participant list, you can send me a direct chat and I'll do whatever I can to help. If you have any questions for the speakers today, please use the Q&A module. You can find it down in the bottom toolbar in Zoom. We're going to be pausing after each speaker and they'll address whatever questions we have queued up there for that part of the presentation. If anyone has any questions about that or has a hard time finding it, you can also go to the chat and reach out to me and I will do what I can to assist. If you would like to have live captions, I'm going to enable them now and you're able to turn them on also down in the toolbar on Zoom. On. So if they don't automatically pop up right now, you can turn them on down in your toolbar. At the end of today's presentation, you'll be redirected to a very brief survey. It's really important to us that you take 2 to 3 minutes to fill it out. The survey lets us know what you thought of the presentation. It helps us determine what kind of training and technical assistance we can provide to you all in the future. And it also is reported to our funders at SAMHSA. And then everyone who attends will receive a certificate of attendance. We send those out via email and you can expect those within about 2 weeks. If it's been longer than that, do check your spam folder or junk folder. And if you have any questions or aren't seeing it, please also reach out to us via email. If you haven't already, connect with us on social media. We're available on Facebook, LinkedIn. We have a YouTube channel, and you can also find our podcasts on Anchor and Spotify. Today's presenters are Dr. Mike Flaherty, Zach Thomas, Precia Stuby, and Ginny Williams. And I'm going to turn it over to them to do further introductions and get everything started. So thank you once again for joining us today.
Thank you, Christina. While we're getting the slides, can everybody hear me?
Yes, we can hear you.
All right, great. I am Mike Flaherty, a clinical psychologist, and I'm very pleased to be with you this afternoon and go over this part 2 of our 3-part webinar series on recovery-oriented systems of care and how they can meet America's mental health and substance use needs. Today, our focus will be specifically on the workforce and workforce development. And you will hear from a number of our speakers how they personally have implemented workforce development, recruitment, and retention in advancing their systems of care under a recovery-oriented system of care philosophy. Next slide, please, Zach. My particular focus will be in addressing briefly some of today's America's mental health and substance use needs that you all are quite aware of, I'm sure, but I will bring some back up. We live in a world of information overload, and too often it's so easy to put these things in the back of our mind. But we who work every day in the field know that we face these issues that you'll see in that particular part of my presentation. Workforce needs and plans and solutions. I will review only two. There are many, but I've highlighted two for our presentation today with some solutions. And then I and the other speakers will speak to how ROSC enhances workforce development and retention. Next slide, please. Our situation today in America based on workforce was made known to us quite prominently during COVID, where many of us had to resort to telehealth and non-personal interviews. We also learned about many people in our country who were not getting behavioral health care until we had telehealth and other ways of accessing information and treatment. Roughly 2,000 or 3 Americans are unable to access mental health services in America today. I'll explain where that comes from in a second. Half of our Americans live in what we call mental health diagnostic shortage areas, health provider shortage areas. Roughly 160 million Americans live in a part of a country where there is no mental health service personally within 50 miles. And this defines it as a mental health provider shortage area. We found this out again during COVID. So half of our citizens don't really have access to mental health, and those that do are having a hard time even getting it. America has less than 1/3 of the psychiatrists it needs today for mental health and substance use services. I picked that as only one profession. I could say the same of counselors in drug and alcohol, psychologists, social workers, nurse practitioners. We're all short. Access to care is geographically very non-uniform. Urban areas have sufficient, but usually waiting lists because of backups and wait time to get into treatment. And rural areas just simply don't have access to personal care as much as urban areas. So you have these gaps around our country. And the new phenomenon that has come about in the last 5 or 6 years, public health services now are becoming training grounds for private health. I call it the private health divide. Many counselors receive the training in public health, graduate, get their degrees, and then realize that the incomes and salaries they can draw are much higher on the private side of the equation and leave public health service, something we have to address. Next slide, please. How has this affected our population health? Well, I could go on all day. Our mortality, age-adjusted mortality rates are gone up in the United States, mostly because of opiate use disorders. We are almost 13 times higher than the rest of the world for death for opiates. We now shows that we are up much higher than we've ever been, and our death rates and longevity rates are so high that our longevity rates are coming down. The life expectancies. Canada, on comparison, 85% of their citizens who have opiate use disorders have access to care. Here in the United States, those seeking substance use disorders barely break the 20% mark. So, and the data here that I have all the citations and references for you at the end of the presentation. Interesting. Next slide, please, Zach. This boils down to 45 million Americans in America with a mental health diagnosis today, of which only 39% receive treatment. 22 million Americans diagnosed currently, with only 1 in 10 actually receiving treatment. And that's really based on what we have capacity for. If the other 9 came in for treatment, there wouldn't be capacity. So we really are in a dire strait, which has been predicted for almost 15 years in this country. Next slide, please. Why do we need workforce? Well, between 20 and 21, suicide deaths have raised in our country, 32% increase. And drug overdose deaths, if I have mentioned, have gone up 376% since 2001. Last year, we did have a small drop in overdose deaths, but we had an increase of overdose deaths due to fentanyl, and that problem is growing in our country. Interestingly, too, since July 22nd, when the emergency text hotline 988 was launched, we have received over 23 million calls at that 988 or text since its launching just about 2 years ago. So you can say that our country really does need more mental health and substance use services. Next slide. I took some time to look at your individual states in the presentation today. These are the states that are in the Great Lakes ATTC network, and the Milton study that you have in the citations, the first citation, looked at about 16,000 of your commercial Medicaid, Medicare behavioral health claims, found here proportionately, Indiana's had 34% of its enrolled members in commercial Medicaid or Medicare claims. 34% were in behavioral health diagnosis. Illinois, 34%, Michigan, 40%, Minnesota, 37%, and Wisconsin came in at 38%. Some of the numbers are a little jumbled here in the translation, but the national numbers, aren't there, of course, because we didn't compare national. But the idea is that you can see where your behavioral health diagnoses are. About 30 to 40% roughly of people in your insurance are qualifying for behavioral health diagnosis. Overdose deaths in your individual states, you can see the numbers there. That's 2023 data. And you can see where you came in those states as to the per 100,000 quota. The national 32.4. If you take all the states in the country and say what's the average overdose deaths per 100,000 in America, it's 32.4. And as you can see, some of the states in your Great Lakes ATTC region are above that. So that some of your problem with overdoses are actually going up, even though the overall national numbers may be coming down. Next slide, please. This rather busy slide I'll only highlight momentarily because it's just so busy, but it's a wonderful slide by the National Council of Mental Well-Being. And just highlight some of the big numbers, surveying the counselors in the field, mental health and substance use counselors, they themselves report that 83% believe that workforce is not going to be able to sustain the challenge unless there are major policy changes in the near future. That's an existing model of treatment as usual in the way we credential, certify, and train people. 83% felt that the system itself is right now very fragile. 90% felt that there was problems with access to care. 87% believed that that the care provided was not as what they really would have liked to have given. 2 and 3 believe that the caseloads are going up faster than they can really get to people. And more than 7 and 10 reported the increased severity of the illnesses they were seeing in their offices. 93% said that they had occasionally felt burnout. 62% felt that they were clinically in help for burnout. 48% of the agencies surveyed said they had constant help wanted signs for recruitment. So you can see we have a major issue. And this should not alarm you because this has been predicted in numbers of studies for the last 15 to 20 years. And the first one we'll go to now. Next slide, please. What this all boils down to, though, is that if today we were to say, let's wave a magic wand, and how would we fill up capacity so that we could meet everybody who was enrolled in the existing services, and I emphasize in the existing services, this would be what we would need to bring everything to equilibrium, just to cover everybody, or about 8,000 more behavioral health workers today. And you can see the growth areas, child psychiatry is one of the shortest, and some of the increase in addiction counselors and mental health counselors are the ones that are really in more demand today in our public service arena. Next slide, please. Of all the plans, and there are many, I took 2 that I thought I'd emphasize today for solutions and what we can do to address this. The first one is the Action Plan for Behavioral Health Workforce, derived by the Annapolis Coalition on Behavioral Workforce Development, of which, in full transparency, I am the board chair. Why I took this is not for that reason. I took it though, because in 2007, we wrote this on the basis of surveying thousands of counselors in mental health and substance use, and but more importantly, the agency directors in almost most of the programs across the country, and found out that the problem was even more acute than we thought. We wrote this plan. A copy of it can be had by going to the link you see. It's a YouTube presentation by Dr. Michael Hoagie, who so well describes everything in the plan. We derived at that time through panels that we wanted to broaden the workforce, strengthen the workforce, and build structures to support the workforce. And that would be the underpinning of a workforce development. Remember, this was in 2007, and that's why I chose it. This was almost 20 years ago, and yet how far have we not come in that time? Anyway, let's look at some of the things we recommended in 2007. Next slide, please. First, to expand roles for persons in recovery and their families. Today, we all know that peers and peer recovery specialists and family members, recovery coaches are involved. Well, we seem to hear that one and move in that direction. Perhaps not far enough yet, because I've looked at salaries in states. Some states still don't recognize peers, most do. And in fact, recovery coaches is one of the most largest developing, fastest developing careers, and oftentimes, again, outside public health system, which is somewhat concernful. But that one we addressed. Expand the role of communities in the development of public health. Well, we certainly have done that through a recovery-oriented system of care, through anti-drug coalitions, and through oversight in the community. Expand the role of health and social service providers. This was how we expanded work into the community by doing things like introducing SBIRT, screening and brief intervention, integrated care and recovery models of care, giving templates that people could use so that care became more unified and in an organizing manner rather than just a simple episode and gone. So by doing earlier brief interventions, we brought in nurse practitioners, we brought in not medical staff, but other staff who could do a brief screen. We expanded our workforce by using the technology we have and the knowledge we have to bring other workers to develop that knowledge. And that was another way we recommended, and you'll see in the next speakers. Next slide, please, Zach. Systemic recruitment and retention of diverse workforce. This really boiled down to setting pathways, and today there are fewer pathways in our graduate schools, in our community colleges. If you look at them, you'll see fewer numbers of pathways for people to become certified as a drug and alcohol counselor, mental health counselor, social worker, psychologist, recovery coach, any of these, but there are fewer numbers of these career paths. It's simply because of where the incomes can be found and the better jobs can be found in other areas. We need to go back and find that, go deeper into young people and recruit them sooner, even in high school, to be thinking about how they could help, or second career people in later life, or coming back, or excellent candidates for this particular recommendation. Increase the pipeline relevance, effectiveness, and accessibility. We've certainly done that by making careers out of it instead of jobs. So have train somebody as a counselor, but also give them additional credit so they can become certified as a social worker, become licensed, making it a career, not just a job. Training and development of supervisors and leaders. This is a very important one for the ATTCs. Do so much in clinical supervision and SAMHSA itself. But clinical supervision outside of public health is not nearly as strong as it used to be, because simply it's not paid for. So we have to define ways of giving support to clinical supervision by making it paid for and part of standard clinical care. Next slide. Financing systems that enable competitive compensation. This we spoke about earlier in terms of getting skilled and credentialed in your public health side and jumping to your private career, or because of salary changes. There are ways that creative agencies, even the one that I'm on the board of, Community Care in Pittsburgh, speaks to incenting counselors by giving higher reimbursement rates in their managed care contracts for retention and recruitment and for quality services. You can do that. You can give bonuses at the end of a year. There are ways we can keep our workforce if we decide to sort of get waivers or step outside the box a bit and find ways of keeping people. Many agencies are turning to doing their own training internally. A little dangerous in a sense, and you want to be able to get outside neutral perspectives, but on the other hand, it's also a way of reinforcing getting continuing education credits at a much lower cost. Technical assistance infrastructure that promises best practices for workforce, another newly developed need. How do we keep our workers over time? How do we invest in them? How do we make new people want to get part of this? Maybe it isn't all just formal direct care. Maybe it's support care or referral to care skills that we're going to be building. And number 9, and the last recommendation of the Annapolis Coalition, tracking all of this, evaluating it, reporting it back to states and counties so that they had a good idea that workforce was not only being developed, recruited, but contained and sustained. Next slide, please, Zach. This was the second study I chose as one we should at least know about going forward in solutions as we build ROSCs anywhere we are. And U.S. Surgeon General's report, which recently came out in 2022. And this particular report will be featured in a later presentation by my colleague, Precia Stuby, as one that was very looked at very closely in her development of her programs in Hancock County, Ohio. It's a wonderful report, and I think anyone working with workforce should be aware of what's in this report. I will not say any more about it today. Next slide, please, Zach. Coming down the bend here. A recovery-oriented system of care. I wanted to remind all the people attending today's conference is a network of community services, not just a licensed drug and alcohol program or mental health center, but it's all of the community services. So there's your one expansion of workforce by bringing in first responders and police and harm reduction specialists and all of your LGBTQA specialists. You're expanding by need to a new workforce as those community services that you're bringing in the network, which makes recovery possible. So you support that based on person-centered needs, driving what you need for a workforce, not just all PhDs or MDs or similar, but you need that team approach from the grassroots up to make your workforce, and this improves your health, wellness, and quality of life. Next slide, please, Zach. So in summation, a ROSC does enhance workforce. It expands the roles for entire community being possible, especially persons in recovery and their families, peer specialists, family advocates. We mentioned coaching. We have clergy now becoming qualified as counselors. ESPER being used by clergy. It's getting out of the framework that only those people who are licensed and medical providers can help with the problem. And this is what a community up model or ROSC does. It brings in a whole community to solve the problem, not just the healthcare field, and puts the burden just on the healthcare field. So doing that, we decrease stigma, which makes everybody more capable of working with one another. We peer support, which is available 24/7. We found out during COVID that people were attending support groups in Greece, and people in Greece were attending support groups in Peoria. It's just a wonderful thing to expand the consciousness of what is a worker today, or support group. Warm handoffs brought along to close gaps when people would be transferred from one facility. We brought peer supports to bring in warm handoffs and to make sure these things happen, improve retention and compliance enormously. Community connectors and informers, the leaders who speak to recovery and could make sure that the community itself was on board in making the decisions and oversight of what is a ROSC, bringing more community people to the table, parents, people who've lost somebody, sadly, pregnant women and who have raised children in this environment. Having those voices will heal not only the person, but the community. improve treatment and recovery outcomes, and we'll talk about that, particularly in the last third webinar, August 15th. Most of all, thinking of it this way, keeping the focus on recovery, which is much more than today's treatment as usual of episodic care or, just one kind of care and then moving the person on to another care, but building on a recovery measured model of care. Next slide, please. Finally, expand the role of communities themselves. This is what you bring new workers in through the coalitions you form, the oversight of peers, the participation of leaderships in government. The counties that you're about to see, Precia and her county, and Hancock has mayor and council members involved. Everybody's involved. The chief of police is involved. The warden's involved. These are all involved, and they're involved in substance use and mental health issues and concern. We're learning. We're expanding that learning. That's what ROSC is. Programs more tailored to the community need and to diversity, equity, and inclusion as a focus. And you will see some of that in the presentation given later by Zach. Sustained awareness and voice of the community. The community is healing itself. It's empowered to do so through its voice, and that voice is that of a new worker. Build measurable community wellness. Recovery capital is the aggregation, the strengths that you put into a person or a person brings, which adds to the strengths of the family and the strengths of the community, which is recovery capital of community, or known to some as population health. How much is the improvement of health in the community through the improvement of these conditions in a community. Next slide, please. So one sentence, a ROSC strengthens treatment and recovery, not only by developing and utilizing an expanded workforce of the full community and peer supports, but by also measuring improved wellness and recovery across a continuum of care, even over a lifetime. And that's what makes ROSC so strong. The individual is continually in recovery over a lifetime, and many of us know that. Next slide, last slide. I now have a pleasure of turning this over to my so valuable, wonderful colleague, Precia Stuby, who's the director of the ATTC board and programs in Hancock County, and who I've had the pleasure of working with in implementation of many of these programs over the last 10 years now. So Precia, please take it from here. Let's go to our questions.
Okay. Good afternoon, everybody. I hope you can hear me okay. I'm Precia Stuby, and thank you, Dr. Flaherty, for your kind words and for your introduction. Before I get started, I just wanted to take a moment to thank all of you for joining today. I know the competition for everybody's time is very tight, and we don't propose to have all the answers. I really don't think anybody has in relationship to workforce. But my hope is that by us sharing and people continuing to share between and among one another, we'll continue to bring solutions to the field. Zach, I'll have you go ahead and take it to the next slide. For those of you who aren't from Ohio, I'm the director of an alcohol, drug addiction, and mental health services board. And basically what that means in Ohio is that public funds come to a county level board, and then that county board contracts with service providers to make sure that there is a system of care available to individuals, especially those who couldn't otherwise afford that care. Hancock County is we call ourselves a micropolitan. We're a population of about 75,000 people in Northwest Ohio. And as such, we have all the typical agencies and organizations you would think of, as well as a local university and a local hospital. Dr. Flaherty mentioned the issue of ROSC, and we have been working with him since 2013. So we're over 10 years in working on our transformation. And so the issue of workforce has been a discussion with us for all of that time. And so first I want to talk a little bit about what we did kind of in the first 8 years. So Zach, I'm going to have you advance the next slide. one of the things that Dr. Flaherty really encouraged us to do is to think of career ladders, think of, building access for individuals. In a ROSC world, you cannot be successful in ROSC without bringing in a peer workforce. We also needed to develop a workforce and expand our workforce in the substance use field. So I'm first going to talk a little bit about what happened with trying to build that career ladder in the peer world. This concept of peer guides or battle buddies, if any of you have had an experience with hospice, you know that some of the best hospice volunteers are from families who have gone through the hospice experience. And they're hospice volunteers that go out to families that are going through a hospice experience, and they are very able to provide empathy and support to a family unit going through that experience. That is the same premise that we used in our community to develop the concept of peer guides. Peer guides are individuals with lived experience who want to volunteer. They volunteer to support others who are going through a lived experience. They are not paid. They are not employees of treatment agencies. They are volunteers that are linked to our recovery support center. Battle buddies are the same concept. They are volunteers, but they are volunteers who are veterans. And then they are linked with other veterans who are also having challenges. So we wanted to create this open door for people to volunteer. Some people stay in that rung. That's where their comfort zone is. That's what they want to do. And they never decide to go any further. And that's wonderful. We keep them. For others, it's a way for them to put their foot in the water and say, gee, this is a career I think I might like. So then we move up the ladder and we have paid peer support positions. In the state of Ohio, we have a certification for peers, and peer services are reimbursable by Medicaid. We have peer support specialist, youth peer support, and family peer support. So there's actually 3 categories of peer support certification that you can receive in Ohio. In our community, we are up to 32 paid peer positions across our system. So as I mentioned, our board is an entity that contracts with agencies. We don't contract with agencies unless they have peers on their staff, because we are committed to the value that lived experience can bring in the delivery of services. So that provides the opportunity for individuals who are peers and want to work to be in different environments. So for example, we have peers that work at our hospital, our health department, our treatment agency, our recovery support agency. We have people in our recovery homes. We have a stabilization facility that we hire people with lived experience. So we're trying to create multiple opportunities for peers in our community. The problem is that with that employment, often they'll be like, well, I'm a single peer that works at agency X, or there's only 2 of us at this agency. So what we wanted to do is create in our community some kind of umbrella organization, way of supporting peers that work in our community, no matter where they work. So under the direction of our Recovery Support Center, we established a peer advisory partnership. And that is only for individuals that either volunteer or are paid as peers. And they have their own board of directors. They have their own a formal strategic plan for themselves as a partnership. But predominantly, they have four major things that they do. One is to serve as a point of advocacy. One is to provide feedback out into the community and into agencies that are delivering services to let us know what's good, bad, or indifferent, as well as serve as a place where any organization in the community can go to them and get their input from a peer lens. So for example, we're in the process of doing our community strategic plan, and we want to take it through this peer advisory partnership to have them review it to see if we've captured everything that they think needs to be in there. And then and support. So what can they do to continue to build the profession in our community and build the support so that we can retain those peers in our community? The biggest example I have of that is we have a professionally led and facilitated monthly meeting support network for our peers. I pay for a PhD level individual to facilitate that. I don't get any information about what's discussed in there because it's supposed to be a network for them, about them. I just get how many people attended and kind of what the topic was in terms of the continuing education. But that partnership exists in our community to provide that ongoing support, education, and nurturing of the peers across our community. Next slide, please, Zach. As I mentioned, we also needed to increase our workforce when we started to go through our ROSC transformation, particularly in the area of substance use, because we were really underdeveloped both in services and staffing to address the opiate epidemic. And as Dr. Flaherty mentioned, we needed to start with the high school. I'm part of a larger committee at the state level, and with the tech prep programs, they have developed some certification programs that can be put in those tech prep programs related to mental health, AIDS, as well as individuals that can go through the coursework, and at the end of the coursework will be eligible for the most entry-level licensure for the chemical dependency. In addition, one of the things Ohio has done is they have contracted with what's called the American Legacy Theater, and the American Legacy Theater has developed vignettes related to mental health and substance use and youth in need of those services and the kind of professionals that go out and respond to them. It's a live theater event that they take around to the high schools as a way of demonstrating what that career path might look like, and as a way of reducing stigma and generating interest in the field. And in our local school, we're just in the process of getting that curriculum in place for mental health and are adding mental health first aid, as well as some curriculum on brain development to try and encourage the youth to consider this as a career pathway. For our colleges at the college level, and Ginny will be talking about this a little bit later, our community definitely tries to take advantage of the opportunity to do college internships. As I'm sure you all know, in the olden days, it was nearly impossible for somebody to receive a paid internship if they were studying social work or counseling. And now we're able to look at how we can pay for that. In the state of Ohio, our governor funded what's called a Great Minds Fellowship. And it's the idea that we can help students with both their tuition as well as sign-on bonuses if they're willing to work in community mental health. There's also a special program to help pay for individuals returning to the workforce if they have been out of it for a while and coming back in. And then finally, part of our career thing has been this development of a certification / minor at our local university. So when the epidemic hit, you know, we would see many, many people hit our emergency room with an overdose, which was kind of unusual for the nursing staff, the doctors, the pharmacy, so on and so forth. And so one of the things that we talked about is how can we make existing professionals in our community, if they're in an allied field, more familiar with substance use so that they would be that much better at responding. And then there was this issue of how can we make our graduates coming out be better prepared for the field? And how can we take workers in our own field and get them ready for more licensure? So what came out of all of that was this program at the University of Findlay, and it's called a minor / certificate program. So if you're working in the community, you go through it and you get a certificate. That way you don't have to pay the full cost of tuition. And at the end of the coursework, you have completed everything you need to apply to get your entry-level licensure in chemical dependency in the state of Ohio. If you go through the program as a student, instead of a certification, you actually come through with a minor in substance use disorders. And that way, the practitioners, you know, so you can come out as a social worker with a minor in substance use disorders. You can come out as a physician assistant, a physical therapist, so on and so forth, to the point that the university has made it a requirement for some of their health professions. So for example, you cannot leave our local university as a physician assistant without also having a minor in substance use. And we're really proud of that because we think that no matter what health profession you're in, the likelihood of coming in contact with somebody who might struggle with substance use is very high. And we feel like because they have this minor, that they'll be better equipped to work with individuals that come before them, even though that might not be the primary reason they're coming to see them. And then finally, you know, part of our rung in terms of the development is the ongoing training and support that's available. The ATTC is an example of that. Ohio has a number of what we call coordinating centers of excellence, where people that are in the workforce can get ongoing education and support for a variety of evidence-based practices. And predominantly, the cost of that is free. And Ohio just recently launched a center of excellence on substance use disorders specifically. Okay, Zach, next slide. So that's kind of what we worked on for the first 8 years. And then what happened when the pandemic hit and the workforce shortage just became critical. We put our Ross hat on and said we need to be thinking about this a little bit broader. And so we put together what we call a workforce collaborative, and we invited any organization that works in health and human services. So hospital, criminal justice, treatment agencies, schools, everything, anybody like that is broadly in health and human services, and said, we need to tackle this not as individual agencies, but as a community. And so we created a vision for how can we make our community a destination for individuals that want to work in health and human services. So if you think of destination employment, where you might think, well, if I want to go to a law school, Harvard would be the top of the top. Or if I really wanted to work in research medicine, I'd want to go to Johns Hopkins, or I'd want to go out to the Mayo Clinic or something like that. How can we make Hancock County like that destination? If health and human services is your passion and your vocation, come to our community and we're going to find a way for you to be successful. So it started to change the way we think. So if you think about before maybe somebody comes, you're juvenile court, you hire somebody to work at juvenile court and they don't work out and they leave the community. Well, we don't want that to happen. We want to say, well, maybe juvenile court didn't work out for you, but if you're committed to this vocation, let us keep you in the community and let's explore what might be a better fit for you. Are you better in child welfare? Are you better in mental health? Are you better in healthcare? And the idea across our collaborative is that we don't let anybody leave our community, that this is where they want to practice, that we work between and amongst ourselves to help them be successful. So to do that, Zach, next slide, we came up with 3 big buckets of work that we wanted to take on. The first bucket was everything in relationship to education. So what do we need to do going down into that middle school all the way through college? How do we really need to fill out that whole ladder? How do we need to make sure we have the right MOUs in place, the availability of internships? We're taking advantage of working with the high schools as they are helping people study their aptitude and their interest. How can we expose them, take full advantage of anything that's available in the education system, and how can the education system take full advantage of everything that's available in our places of employment to marry those two things? So that was one bucket of work that we said we really need to explore that. We are 2 years in, and so we still have work to do on that. But that's one big piece that we're working on. The second big piece we're working on, as we started this a couple years ago, we heard about people doing sign-on bonuses, work from home, that kind of thing. And what we wanted to do is say, we know there's like the top 10 things that you can do, but how do we do them knowing that we're doing it in the most impactful way? What's the best practice related to each of those things that are known to work to impact recruitment and retention? And then the third body of work was, what are some of the non-traditional things that we can do that change the conversation, that change people's desire to be involved in this work? And, while there's not as much science around that, the things that we were reading about that is that it's some of the non-traditional things that seem to be the most impactful. So, for example, the concept of having a bowling league across different agencies, ways that they can recreate, ways that they can be connected, is really an impactful way of having people stay connected to their job and connected to the community, and connected to the on the previous seminar, you heard me talk about the issue of moments and milestones, the issue of changing the conversation, and the success and failure, not from, overdose, a client who overdoses and dies is a failure, a client who dies by suicide is a failure. And think about, what is it we're offering that individual and their family the entire time they are engaged in treatment, allowing that individual and that family to celebrate moments and milestones and not just think of success and failure as life and death. So we started working on all of this work, and we decided that we needed some outside help. We wanted to bring in a consultant. We found that to be very, very challenging. Everybody and their brother wants a consultant in this field. They're hard to find. So we were successful, and we were able to find someone. And right at the same time we found someone, the Surgeon General's report became available. So Zach, I'm going to have you go to the next slide. I know that Dr. Flaherty brought up the picture of the Surgeon General's report, but I'm going to have you bring up the diagram that's actually in the report. He's so good to me. There we go. So the Surgeon General's report is really on mental health and well-being in the workforce. And it's like, these are the content areas in the report that says, if you address these areas in your place of employment, this is how you are going to be successful in your recruitment and in your retention. So this is applicable whether you're an automotive industry, a service industry, or a health and human services industry. So what we did with our consultants is we asked them to take each of these categories and do the research under each one specifically related to health and human services. And so that's exactly what they did. They took like protection from harm and looked at anything that was available in the literature when you localize that to health and human services to identify things that could happen and become available in our local community. So Zach, if you can bring up the final report. So and you'll all have access to this, so it might be things that you'll be able to take nuggets from this, we hope. So for example, like this flows right from the Surgeon General's report, the section on protection from harm, which is the definition. And then there are action items in the report that you can do related to protection of harm. And then what they identified was examples of best practices that could be put in place if you are an employer of health and human services. And so when you get this report, if you want to take it, each of those are live links. And so you could actually click on it. It will take you right to the research associated with that so that you can pick and choose what you think will be most appropriate in your organization. And as you can see, Zach can scroll down real easy on this. There's like 23 pages. It goes through each and every section that's in the Surgeon General's report. And then there are evidence-based practices in each area that you can look at for health and human services. So after we got this, thank you, Zach, I'll have you move on to the next thing. What we did is the agencies that are involved in the collaborative, they were like, well, that's great that we have all this, but is there any way that we can figure out, like, self-assess where we are in relationship to those 5 categories that the Surgeon General has identified, localized to health and human services? How can we do a self-assessment? And so we worked with our local organization called Raise the Bar. They're kind of our workforce coalition in our community. They work side by side, and they had predominantly had a history in helping our manufacturers in our community. And now they've really expanded the scope and breadth to help us. And so they took every piece of that. The consultants helped us develop a self-assessment tool. Raise the Bar took the self-assessment tool, put it into a SurveyMonkey format so that you can complete the survey, and then you will have at the end of that, like a self-assessment of your own organization in relationship to those 5 categories. So I'll just give you like a very quick example of when we did this in my own organization. You know, safety was the area that we scored the lowest in. And, you know, years ago, our safety policy was modeled all throughout the state. And now all of a sudden it has the lowest scores in my office. And what happened is our current safety policy, when we compared it against the self-assessment tool, was completely silent on the concept of psychological safety and what we were going to do to ensure psychological safety in our organization. So we're in the process of updating that policy in our own organization. So that's an example of how it could be used. So again, we're sharing all of this information with you in hopes that there might be some things that you might be interested in. Zach, the next slide. Zach is actually the person that I am going to turn this over to next. I wanted to make sure that you knew that we also know it's important to tend to diversity and inclusion. We really focused on 3 areas in relationship to that. How do we make sure that the governance of our local organizations is inclusive? How do we make sure that the individuals that are delivering services, that we have diversity there? And then how are we tracking and knowing that the individuals that are actually coming into service are reflective of the makeup of our community? So with that, I'm going to say thank you and turn things over to Zach.
Thank you, Precia. I appreciate that very much. We had an opportunity in 2021 to take advantage of some of our state opioid response dollars to focus on something related to diversity, equity, inclusion. And we put our heads together and we're thinking about this work that was just starting with our workforce. And what could we create that would be helpful at a systems level, at a community level, that would be reflective of trying to ensure that our workforce, one, feels a sense of belonging and connection, but as Precia was saying, that is reflective of the people that are being served. And I'll talk about the we as a coalition we have called the delegation. But we decided to reach out to our consultant that had been working with us on a large strategic plan on how do we as a community address diversity and inclusion at a broad level, not just in workforce, but in all aspects of our community. And this organization really decided, hey, we will help you move this forward as it relates to developing this process of training and a toolkit to be able to expand this knowledge and capacity to address the workforce. And so as Precia had mentioned, there are 3 areas within our training or our toolkit that were created. And just to repeat those, again, on the governance level, we really want to look at those best practices that governing bodies, whether it's a board, whether it's administration, whomever is making the policies and practices of that community, what are the best practices that are needed to implement and ensure that they're addressing the cultural makeup of their organization? And also addressing any disparities that might come up, and how do we effectively address those in order to make sure that the people that are working in the organization are feeling safe and secure, to speak to that psychological safety that Precia mentioned, well enough so that they can appropriately address the needs of the clients that are coming to the organization. And then what are the strategies that they can use to implement those governing practices? From the data standpoint, what is the makeup of our organization? What were the best or most salient data points that we needed to know about our own organization that's reflective of the people that we're serving? So, understanding the demographics, the cultural backgrounds, and how does that interplay with the people that are coming through the door? Or if we have an organization that has an entity that is going out into the community, how do they appropriately respond to the people that they are seeing out in the community? And then finally, when it comes to workforce, we have a component of the training that is focused on best hiring practices, where we really look at what are our internal or unconscious biases that influence our decisions on how we hire someone, when we're looking at just their resume, or we're looking at them as a person and thinking what we might expect of them based on how they appear. And so there are exercises and strategies in this toolkit, this training, in order to really mitigate so that we're becoming very inclusive in our hiring practices. I mentioned the delegation. I just want to kind of frame where this group kind of stands in their philosophy and the work that they do. It is a very diverse organization, coalition that has representation all the way from the mayor's office to the hospital. We've had law enforcement be engaged. Certainly our behavioral health workforce is engaged, our library, a lot of our nonprofits, our community foundation are all represented on this group, with really the idea of creating safe spaces in our community. And the foundational philosophy of this organization is based in John Powell's work out of the Othering and Belonging Institute in Berkeley, California. And this diagram is modified from what he shares. And it says that othering, it's very kind of self-explanatory in the picture. You have a very homogeneous group that is the in circle, and you have a group of people that are very diverse, that are outside. And kind of the example we think of is, we're going to have a pizza party and no one else is invited except everyone that looks the same. In the second circle in the middle, inclusion, we often say we want to do inclusion, but what's interesting and we've learned about inclusion is that often we invite people to the table. However, the rules have already been made, the policies have already been created. We're simply inviting them to the table to participate in a structure that's already been made. And so inclusion is not quite enough. The way to think of this is, we're going to have a pizza party and you can come, but we've already ordered the pizza. We've already selected where the music is going to be played, our song list, that sort of a thing, what type of drinks we're going to have, Coke or Pepsi. What we really are trying to strive for is this sense of belonging. And you can see sort of the explosion of all of those circles that are multicolored, different backgrounds, all intermixed together. And the definition of belonging, as John Powell puts it, is having the agency to really be able to participate in a democratic process and place demands upon that democratic process. So in this example, it would be, hey, we want to have a pizza party. Hey, come along with us and help us. We all want to select where we're going to go to get the pizza, and anything else we want to be a part of that. So we're really trying to strive to that right side of the screen where we're talking about belonging. And how this applies to workforce is that a workforce is in and of itself its own culture, its own community. And how can we ensure that you have psychological safety, physical safety, mental health safety, so that everyone feels that they're actively participating in decisions that are being made? That is the framework in which this toolkit was created. The toolkit itself, which you will have access to because it is a public document paid for by public dollars, and so therefore you can utilize it however you see fit. The training itself, the full training that a group of folks went through, kind of the training of trainers practice, was actually 12 hours. And it consisted of all of these things that we're going to be talking about. But the facilitators, after they went through the 12-hour training, said, you know what? This is really great. This is really in depth. However, as Precia mentioned in the beginning of her presentation, everyone is competing for everybody's time. And we knew that it wouldn't be possible to really have this training take hold if we expected everyone to go through a full 12 hours. So what the facilitators did was really dig into the content of that training and take the most critical components that were most important about what we want to try to impress upon our workforce into 2 hours for part 1 and 2 hours for part 2, without watering it down or without diluting it so much that the most critical points do not get across. And so we believe that we've been able to develop that 12 hours into an effective 2-hour training that goes over kind of those basics of inclusion and belonging. And then part 2, which I'll show, goes over kind of that workforce development. So in this part 1, you can see the objectives there of what we're really trying to do. We've been very fortunate to be working with the company that helped us with this toolkit is called Inclusity, and they're out of a town in Northwest Ohio. And what's interesting is that this is work that they've never actually done before, in the sense of working with a community level project. They work with, major corporations and developing their health, HR programs, multi-million-dollar companies. But they had a strong connection with us as a community that we felt that this was important for us to do at a broad level across the county. And so they really have partnered with us in developing this. So what I will show you related to the workforce piece, they hadn't done with anyone. They actually developed it simply for our ask. And so now we have this piece of work that we can share with other people to help develop their work in the community. You can read the objectives there, but one of the things that I think is really important to know about any cultural and diversity training is that often, well, first of all, when people are told they're going to be attending it, often we get moans and groans. And we can see the political culture as a change, where that has gone, and how actually some corporations and organizations are actually pulling away from focusing on DE&I. But what we're trying to impress upon the participants or we're trying to encourage people to take the training is that if you can think of a staircase, and at the top of the staircase is, where we ultimately want policies, procedures, and people to be when it comes to cultural awareness and cultural sensitivity and inclusion and belonging. And often when you participate in a DE&I training, the facilitators are standing at that top stair, looking down at everyone in the classroom that's maybe at the last bottom stair, or maybe they're halfway up, but nonetheless, they're below. And there's a lot of shame and, uncomfortableness that happens because the facilitator is trying to really pull them up to that step. What we have learned in this process and what Inclusity taught us is that, we're going to come down to that step where everyone is and say, hey, what's 1 or 2 things that you could do that we can go up to the next step, then just the next step together, right? How can you change your thinking? How can you change your approach to someone so that we're ultimately working towards the top of the stairwell, but that, we're going to take it as we can in steps that are attainable at a level and a pace that works for all of us. And so that's really important. And one of our facilitators said that in any of this work, we really have to give ourselves grace because we all want to do the right thing when it comes to inclusion and belonging, but we make mistakes and that's okay. And so not only to give grace to others as they respond, maybe not the right way at the beginning, but also give ourselves grace as we're going through this process. A couple of the models that are used in part one are demonstrated here, and these give opportunities for your organization, your workforce, your teams to be thinking about who they are and who they are as they come to the organization, what they bring with them, both their internal characteristics and but also how they've been influenced by the community that they grew up in, their families. And that's the elements of individuality model that you see at the top. But even more importantly, when it comes to workforce, the social distance shadow model really takes a look at how we carry ourselves and how it may influence or overshadow other people that we're working with, and even how policy can overshadow people. And so there's a lot of discussion that happens in the part one training for people to talk about kind of what does that image even mean, and how might that be affected or demonstrated in our own community, our own workforce. And so all of this is in part one, and we have set an expectation that the part one training is prerequisite for the part two training. Because if you're going to be talking about policy and be talking about development of climate tools, you really need to have a foundation and a grounding in what it is you're trying to achieve in your workforce in order to make sure that you're creating a sense of community, psychological safety, and belonging. So anyone, whether you're in a workforce or not, part one is absolutely going to be beneficial. And we're hoping that many people will want to take this training in our community. Part two focuses on those very specific workforce things. And there's 4 major areas that are in that training. And this is a second 2-hour training. So if you were to do all of it, it'd be 4 hours. So hopefully an organization could, give up 2 hours, 2 different days. They could do all 4 hours in one time, but nonetheless, no more than 4 hours is what is being asked of the participants. But you can see the 4 things that are covered there. Really talking about, what is the business case for doing inclusion, right? Like kind of what's the bottom line? And why is this important to think about our organization as a community, as a culture, but also how that impacts the people we serve. The inclusive policy tool, really digging into our policies and procedures and looking for hidden things that we didn't necessarily think about. And the next slide is going to talk about some of those things that maybe we don't always think about when we're developing policies. And also want to give gratitude to Family Resource Center and Ginny. She participated in the early development stages of this, as having her policies be reviewed as an organization and being kind of looked at kind of what can we do to develop this tool. The climate survey tool focuses on the demographics again of the people that are working for the organization, and how that's reflective or maybe not reflective of the people that are coming to the door, or how they're going out in the community and who they're serving, and making sure there's connections there. And then finally, the inclusive hiring component is, again, those exercises where they look at resumes, they look at interview questions, and how is unconscious bias or discrimination unduly in place within those practices, and how can we mitigate that and change our thinking on that. What I want to share with you specifically is the inclusive policy tool. And then this in and of itself has 4 areas in which we review. And just a couple of things to highlight that I thought were really unique to this part of the training. When it comes to types of policies, Inclusivity shared with us thinking about curb cut policies. Do we have policies in our organization that address our workforce? Think about the ADA. The American with Disabilities Act, and how sidewalks are required to have curb cuts so that someone who might have mobility issues can go from the street to the sidewalk very easily without having to go up and over the curb. So are your policies created in a way that are beneficial to everyone, but also beneficial to those who may have some additional disparities or other health issues? Another policy tool that you would look at type of policy would be poll tax policies. These are policies that an organization can write that may appear equal, but disadvantage some other person. For example, let's say everyone has a work schedule that everyone must work, from 8 to 5. No exceptions. Everyone's treated the same. However, if you're trying to be accommodating to your workforce and you have members of your organization that have to take care of kids at school, is there any flexibility given to that? If you have someone who may need to work from home for a while, do you have flexibility in that? So looking at poll tax policies, and that relates to the idea that we used to have poll taxes, but not everybody could accommodate their policies, their poll taxes, could not necessarily afford to pay the poll tax. And then finally, the old boys club policies. These are things, that we have, way we've always done it. We're not looking to change it. So those are the types of policies that you would explore. Tests for current policies, looking at ways, can you change it so that you're looking at access and clarity and terminology. How do your domains to consider in policy development? And then finally, writing inclusive policies. There's practice tools in there for you to be able to do that. It's a very practical experience for people to go through this training. We are hoping that not only our businesses, but our, certainly our health and human service workforce, our nonprofits take advantage of this. That was what I wanted to highlight specifically about our toolkit. Again, as I said, you will get access to the toolkit as well. It's going to be everything, not only the facilitator's guide, but also the participant's guide, and that is available to you. And so as we roll this out, we haven't done a virtual version yet, but that may be coming down the pike. We'll see. But we're excited to roll this out and look forward to seeing how this gets implemented within our workforce. And hopefully it helps build a better sense of culture and psychological safety among our communities and our workforce. I appreciate the opportunity to share this, and I would be more than happy to turn this over to Jenny for her to bring us home with her presentation. Jenny.
Thanks, Zach. My name is Ginny Williams, and I am the Chief Culture and Transformation Officer for Family Resource Center, and excited to be able to have the opportunity to share with you just a little bit about our journey as an organization related to our workforce. So Zach, you can go ahead and move us to the next slide. This is data that Dr. Flaherty also shared, but I think it's just always a good reminder of what we are probably all familiar with. And realities, especially pertaining to the burnout and the difficulty maintaining our workforce in the behavioral health industry overall. And next slide, Zach. I really wanted to just give you a sense of who we are as an organization and what we do. While that sounds like a really kind of benign statement, I will tell you that that statement of who we are and what we do is really fundamental to our culture here at Family Resource Center. And so I thought it might be helpful here at the beginning just to give you a sense of who we are as an organization, some of what we provide, because ideally, as I share some of our initiatives, hopefully you can get a little bit of a sense of the scale or what size of organization we are and what we provide and how we found some success in certain areas. Next slide. As an organization, we do serve the entire lifespan. We provide both mental health and substance use disorder treatment, along with evaluation and management services. We are licensed by Ohio MAS and accredited by CARF. And I also think it's important for us to note that we are also a CCBHC. We received one of the initial demonstration grants. Actually, we were one of the first two in the state in May of 2020. And then we did receive the implementation grant in September of 2022, which ties in directly to the relevance we place on our workforce. We know from some of the data that we've shared that those elements of staff having to be focused on administrative tasks, their overall workload impacts their longevity with the organization, impacts our turnover rates, et cetera. And certainly with the CCBHC model, and as having a greater emphasis on the quality of care that is being provided, it does at times put additional strain on our workforce. And it's something that we've had to become more attentive to as we've embraced that CCBHC model. Next slide. This gives you just a general sense of our size and scope. And we as an organization serve 3 board areas. As Precia described earlier, most all of our locations are in what we would consider to be rural Ohio. Our furthest northern location is our Hancock County location. It is also our location in terms of our continuum of care, where we provide anything and everything from prevention and awareness services all the way to residential treatment. So it does make our Hancock County location a little bit unique. That is also where we have the bulk of our staff. Our next board area that we serve is referred to as the Allen, Auglaize, Hardin County location. And that location is also a bit unique in that those are our smallest office sites, and also the sites that are located in some of our most rural communities. And then we also provide services in the Shelby, Miami, and Darke County. Our organization has about 200 full-time, part-time, contingent, and on-call staff, and about 30% of our staff are either partially or fully remote, which also adds another unique dynamic to serving the needs of our workforce. We have, for example, a very robust team of telehealth clinicians, and while they are all licensed to provide services in the state of Ohio, they actually represent like where they are actually living, 6 different states in 2 different time zones, different from us here on the Eastern time zone. So that definitely impacts some of the challenges we face. Next slide. I would say that our journey of focusing on our workforce really began at a point in time where Family Resource Center absorbed the services of 2 other organizations. Prior to that, Family Resource Center had only been a provider of youth and children's mental health services. And when we absorbed those other services, we had to pivot and adapt a little bit. And we had the opportunity, we applied for being part of the Workforce Recruitment and Retention Learning Collaborative that was provided by the Great Lakes Mental Health Technology Transfer Center and the Annapolis Coalition. And it was really an amazing opportunity. And you probably notice here by the graphic that I put on, it was also not an easy opportunity. During the time of us being part of that learning collaborative, we had 3 staff changes just in the team that was working with the learning collaborative. I'm the only person who's still here. So it really reflects that during that time we were participating, we were dealing with a lot of that difficulty of maintaining staff. And the opportunity to be in the learning collaborative really forced us to look at how we were handling elements with our workforce, from recruitment and hiring practices all the way through, how are we maintaining our staff? I would say that our work during the learning collaborative was a practice in trying to overcome that familiar challenge of getting people to be open to doing things in new and different ways. We did definitely have some challenges internally with that kind of approach of, well, but that's not the way we've always done it. And so the learning collaborative really pushed us out of our comfort zone and into kind of that headspace of like, okay, what we're doing is not working, so we've got to try something new and different. Next slide. As we started really digging into our workforce initiatives, we decided that we would kind of focus on these 5 buckets you see here represented on the screen: organizational culture, process and procedure, professional growth and development, contribution and feedback, and recognition. And we really found that we also had to be committed to this idea of just moving forward. Every small step was making improvements, and we had to kind of keep moving and keep finding new and innovative ways, excuse me, to be able to approach some of the challenges that we were facing. We really used these 3 questions, and it looks like some of the language got cut off of the screen here, but we really focused on asking ourselves, where can we find some easy wins? Where do we already have something happening that can create some additional momentum? And where do our efforts align across other projects, initiatives, and things that were taking place? And I'll be really transparent and share with you that one of our first easy wins is that I had heard that a new staff person had started at one of our locations, showed up for work the first day, and there was not a space for that new employee to be for their work. A desk wasn't prepared, there was no chair in the room, and the staff person had to search that out on their own. And we kind of use that as our kind of guiding point of, okay, guys, we can do better than this. This is not acceptable. It is an easy win for us to start with having a welcoming, inviting workspace for a new hire where they show up. So that is kind of how basic we started at the very beginning. I'm gonna try and give you some examples of initiatives or tactics we've taken in each of these 5 areas. And hopefully you can grab on to a piece of one or an idea that you might be interested in exploring. And as Precia said at the beginning, I am certainly not saying all of these ideas are the end all be all, or that we have everything figured out, because I'll also share with you some of the challenges we're still facing. But hopefully it will just give you some ideas or some different things to consider. Next slide. I started with talking about organizational culture because I really feel that it is one of the most powerful levers of change for an organization. And I think a lot of different people talk about cultures within organizations, and sometimes it's difficult to fully describe, define, or put our finger on. And these are some of the ways that we like to describe it and how we like to think about it. Our organizational culture is really, what does it feel like on a day-to-day basis to work for Family Resource Center? What is that actual experience like for the boots on the ground frontline staff? We also talk about engagement with employees, and we really look at that as what is the emotional commitment to the organization and its goals. We also define our culture. As you remember, one of my first slides talked about who we are and what we do. So we have very clear expectations about accountability and what we are called to do as an organization. And that is part of who we are. We do have what we call our guiding principles. Some organizations may call those their values, or things that are connected to how we want our team members to show up each and every day. We have 11 of those guiding principles, and I always use the statement that our guiding principles are more than just words on a sign or something that hangs in our lobby. They are really how we show up each and every day. And one of the first things that we had to tackle is that, one of our guiding principles, for example, is we do all things with integrity. And that sounds great. It looks like, one of those signs that people used to have in their office back in the, 90s. But what does that mean day in and day out? How do I demonstrate that? Or how do I look at behaviors that might not be in alignment with that guiding principle to know where I have to make some improvements? So when we talk about operationalizing for day-to-day examples, we provide staff on their first day, for example, a deep dive into all 11 guiding principles for about an hour. And we talk about how integrity shows up. We use illustrations about accessing our electronic health record system and the limitations with that. We talk about basics about clocking in and out for work and how is that represented through our integrity. So we do a lot with putting our guiding principles into real life day-to-day examples. We also use our guiding principles to celebrate individuals, sites, departments, teams, and we use our guiding principles to identify opportunities for improvement. And I always tell new hires that celebrations and giving kudos are the fun things to do. But our guiding principles only really work if we all truly live them. And in order to live them, we have to have the psychological safety and the courage to share, point out, give feedback when our opportunities for improvement present themselves related to those guiding principles. Our guiding principles are also now incorporated into our quarterly review process about contribution to the overall well-being of the organization. And the guiding principles are incorporated into our annual recognition that we do at our holiday gathering with something that we call the Guiding Principles Award that staff have the ability to nominate one another for. And it is really viewed as one of the most kind of celebrated recognition opportunities within the organization. Also, part of our culture is the fact that we emphasize a team-based approach to client care. We truly believe that everybody is a part of the client's treatment team, and we emphasize that from whether or not it's somebody who takes that phone call in our call center to our enrollment staff, our clinicians, our doctors, our case managers, and especially our peer support specialists, because we believe that everybody has a role to play. We believe that every encounter with a client or a family is another opportunity to support them on their recovery journey, and everybody plays a key role in that. We also, as part of our culture, have focused on workforce expansion, and specifically, those of us in community mental health know that we are often a training ground where people will come, they want to get the breadth of experience that a community mental health organization provides, and then they want to move on. And that can be frustrating. It can often feel defeating for our supervisors. And what we have done is we have tried to use that as an opportunity. We have really embraced this idea that we are a training ground, and we do that by making sure that everybody who comes into the organization understands that as a community mental health provider, we are called to serve those that have the highest level of need, but yet the least amount of resources to get those needs met. And there is something special that comes from working with that client population. There's a great book. It's called Unreasonable Hospitality. It's written by Will Guidara. If any of you are fans of the TV series, The Bear. It was actually highlighted in their second season, and it's about the restaurant industry. But what he talks about is the nobility that comes from serving others. And so we have really embraced that idea about the rewards that come from serving those that have the highest level of need and the least amount of resources. We have also focused that training ground idea, and I think Precia mentioned this earlier, related to our work with interns. We all kind of have those traditional schools, colleges and universities that we work with. And what we have done over the past about 18 months is that we started cold calling colleges and universities that we did not have partnerships or relationships with. We set up meet and greets with them. We invited them to different sites where we had never had interns. And we ended up being able to develop connections with 5 new institutions that we are working with, and kind of really embracing that idea of, okay, if community mental health is that training ground, then let's make the most of it. Next slide. Related to our processes, our procedures, and our policy area of focus, this is the area where we have done a lot of infrastructure development, and we have been blessed by now having 2 rounds of a System of Care grant that has really allowed us to implement the predictive index. For those of you that might not have heard of that, the predictive index is a talent optimization platform that provides a behavioral assessment. And that behavioral assessment takes like probably 5 minutes or under to complete. It's a free choice assessment. And what it does is it really helps us identify behavioral drives and needs of a staff member so that we can get them into the right role based on their individual drives and needs. And this has been kind of an ongoing process for us over the past probably 5 years. And it had the opportunity recently to tie into the Health and Human Services Workforce Collaborative that Precia discussed, because we all came together and we said, okay, what is the one role that we all need to really look at and all in need of? And case management was kind of identified as that role. So we were able to leverage our predictive index platform to create a job target based on the skills and the competencies and interpersonal demands of being a case manager. The applicant who makes it through the phone screening process completes the predictive index behavioral assessment. Then the interview team finds out about their profile, and then they are able to use individually created interview guides that are behavioral based to have a much more effective and robust conversation during the interview process, so that we can match those case management candidates with the best case management opportunity that we have within the organization. So predictive index has been a great tool for us. I think that one of the ways we've been able to validate its use is that our most recent employee experience survey, 89% of our staff had a favorable rating that said that the work they do, they believe makes the most excellent use of their own talents and skills. So we're getting the right people in the right job, which provides them with more satisfaction, which then provides us with more longevity with those team members. Our new hire training is probably the area that we have invested some of the most significant amount of time, effort, and resources. during the time of the pandemic, the kind of, as we were all familiar, the Great Resignation, when I would talk with staff who had decided to leave, many of them would say to me, I just don't feel equipped or prepared to do this job. And what we discovered through that is that we had so much variability in the way staff were being trained that we really needed to, in some way, shape, or form, standardize that so that we had kind of a clear idea about that training process. And I think that that is something that maybe is a little bit more unique if you're an organization that has multiple sites and locations that have a significant geographical span, because it's just hard to get a clear picture on what location might be telling, a new hire during training versus another. So what we ended up doing is that we created a 1 week, their first week, pretty intensive standardized live training process. We have a total of 11 specific training modules that all new hires are trained in, depending on their role. And those training modules are taught every onboarding cycle by a staff member who is a part of the organization who has expressed interest or a passion in being someone who helps train and support new hires. So we have specific training pools. We all schedule and rotate, so no one staff member has to pull that burden all the time. But it has provided us with consistency throughout that training process, and it has set those new hires up with consistent messaging, tools, resources, and connections with, multiple people across all the different sites. So if somebody leaves within the organization, I will often meet with them. And I can tell you that since we've implemented this process over the past couple of years, I don't any longer hear the reason that somebody is leaving is because they weren't trained or that they don't feel equipped. That has kind of, been eliminated for us as one of the reasons being cited that people leave. So that has been definitely a positive addition for us. We also have incorporated some really specific policy changes. The first one I have up here, the training expectations by role matrix, is we used to have people who would say, well, I really want this person to get out there shadowing, the other case manager. So I'm going to just pass on them taking the training on how to write an ISP. Well, now we have it in policy that there's really no, nobody gets out of their new hire training without following all of our standardized training modules. And I know that sounds like maybe a given, but we all also know that sometimes out in the field, exceptions are made, or somebody thinks that because this person has a higher level of education, they don't need to take that training course and that sort of thing. So we just have eliminated that, and we have that identified by role who has to complete what. It was also a great improvement for us with our CARF accreditation as well. We also had feedback, especially from our peer supports, that the traditional requirement that somebody work 90 days before they were able to take any PTO was contributing to burnout or their concern about maintaining their own personal recovery. So we did implement a new policy that new hires are eligible to take PTO that they have earned within those first 30 days. And that has also been a positive policy improvement. It is one of the things that was very challenging to get some support behind, because again, it fell into that hole. We've not done that in the past. So it was a big one to overcome and took us a long time, but we were able to accomplish that. The other was that we had a lot of our peer supports also tell us that the clients and families they were interacting with, they wanted to be comfortable when they had those meetings and had those interactions. And we instituted what we call our dress for your day philosophy. So rather than just having jeans on, Fridays, we allow staff to dress for the day that they are getting prepared for. So if a staff member has to go to court with a client, then maybe they're dressed a little bit more formally versus if they are going to be out in the community meeting with clients. And it's a beautiful day here. And as I've walked around the office, several of our case managers are in shorts and nice t-shirts. And that's how they're going to conduct their business based on what they're doing for today. Next slide. The next area of professional growth and development is another one of our areas of emphasis that ties back to that organizational culture and embracing who we are as a training ground. It is also an area where we've seen some positive feedback based on our efforts. In our most recent survey with our staff members, 87% of them gave favorable ratings that we were providing them with opportunities for learning and development. And some of these opportunities are formal, informal. Our FRC University is a week-long dedicated time every summer where we provide about 10 different opportunities for learning. They're all virtual. It's also open because it's a system of care approach to community organizations and parents, clients, families, where they can sit in on virtual learning times. We also have a system of care leadership academy for professional growth and development. Another one that has been really impactful for us is that we support our staff who are working on licensure or credential advancement. And I know lots of organizations do that. What we were hearing is that we had a lot of people that were having test anxiety. Maybe they had some unsuccessful attempts at passing their exams, and the support they needed was work on that testing anxiety. Maybe they needed the opportunities for test prep. So we tried to approach that in non-traditional ways. We also have done some optional opportunities. We do once a quarter lunch and learns based on a topic the staff want, and we provide them with that time. Nobody takes a hit with their productivity if they want to participate. If we, for example, at the start of the year, we had staff who wanted to learn more about the connection between nutrition and mental health. So we offered that quarter a lunch and learn on nutrition and mental health. Most organizations who provide behavioral health care services, I think, also are familiar with the idea that because somebody has been a great clinician, of course, then they must be a great supervisor. And unfortunately, it doesn't always have that direct correlation. So we started what we call our supervisor cohort, and we work with new supervisors on learning how to create psychological safety with the people they supervise, how to have personal insight and awareness about themselves. And it has led to much more effective clinical supervision for our staff. We also have a program called Launching Leadership and Strategies for Success. We meet monthly for 2 hours with every leader in the organization, and we have had authors come in and speak. We have done book studies, and we have really just provided those forums for people who have an interest in leadership and development to be able to have a safe place to talk about their struggles and to learn. some of those best practices that are out there. I would say the other big thing that we have done too is make room for individual contributors. I think that most of us are familiar with that idea that, you know, you don't have to have a title to have positive influence within the organization. So we make room and we support that. The first item I put on here are recovery milestone recognitions. We had a staff member who said, hey, could we do something to support the recovery anniversaries of our peer supports? And so that individual staff member who was not in a leadership role created a survey. We sent it out across the entire organization, and we asked, are you a person in long-term recovery from a mental health, a substance use disorder? And if so, would you be comfortable being recognized? And if you're comfortable being recognized, how would you like that done? Do you want that to be just private between you and your supervisor? Can your team know? Can, you know, we celebrate that as an organization? And we got really positive response. But if it wouldn't have been for that individual contributor stepping forward, something like that may not have happened. We also do a lot with volunteer committees. We have an equity committee. That committee is made up of folks who volunteer, and they said, hey, we think that the organization should get the MAC certification, and that's the Multi-Ethnic Advocates for Cultural Competence here in Ohio. And so that group selected 30 individual staff members who wanted to complete that additional training to be able to get that certification. Making room for those individual contributors to shine, to have opportunities that they may not otherwise be given, has increased our retention, but also just back to that definition about that, our culture and our engagement, it has enhanced the emotional connection that those staff have to the organization. Next slide. Contribution and feedback is something we have tried to get very structured with. We are good communicators as one of our guiding principles, and it's one of them that staff said we were not doing real well. So we tried to improve that. We tried a variety of ways, but some of our most successful has been that our senior leadership team now goes 1 day per month to the different locations, plus a virtual opportunity for our remote staff. And we are just available for 4 hours. Staff can come, ask questions, express concerns, share client success stories, tell us who's making a difference for them, all of those types of things. So we need to, you know, give those talking opportunities to the staff to hear them. I know I'm kind of running out of time, so I'm gonna, I did bring a copy of one of our rumor has it videos. If you're like most organizations, the rumor mill can get in the way of a lot of great stuff happening. So we took advantage of that, and we have a segment in our internal newsletter and different things called Rumor Has It, and we do videos to address those rumors, and it's been a really positive thing. I would tell you too that support of individuality and fun. Our head of HR always says to new hires, behavioral health care ain't easy, and so we try and find fun ways to get the staff involved. We have a staff self-care committee. They do spirit days. There's some that have a prayer group. We have book clubs. And again, those are all things that we allow the staff to take their time during the workday to participate in without any repercussions. Ducks and Mushrooms is really spotlighting that idea that those non-traditional workforce efforts that Precia mentioned have to be organic, and they have to be unique to a team. We have sites that have embraced this idea of hiding ducks. am putting ducks, like if I'm in an office and I step out to use the restroom, you may come back into your office and there's a little duck. It took tremendous traction and is a big part of that particular location's identity. So support those opportunities. Next slide. Recognition is something we do a lot of, handwritten notes. One of the things that I'm willing to share the letter that we do, but we take our data from our client satisfaction surveys, and if those clients recognize a particular staff member, we take those quotes, and each one of those staff get a letter from our CEO with those quotes in it. I see those letters hanging up in offices. They make such a tremendous impact for staff. Next slide, Zach. I'll go here really quick. I just want to share with you some of our improvements. We have had improved ratings with our employee experience data, our employee turnover data. Since this time last year, we've had a 7% decrease in that turnover. So that's been great. And our client satisfaction data has significantly improved. And I truly believe it's because our staff are more engaged, they're more satisfied and fulfilled, and that transfers to their client care. Next slide. I said earlier, we don't have it all figured out. We certainly don't. We still have silos and stigma, especially in some areas related to our peer supports. We do have trouble with compliance and monitoring in some situations. We're like all other community mental health organizations where compensation is a big challenge, and we're trying to work on those things. Next slide. I did share just a few of the key resources that we've invested in that have become part of our language, and they are great resources, especially with anybody on your leadership teams to invest in. Next slide. And then I wanted to share with you this great resource that came out in May of this year, but it was from the Center of Workforce Solutions, and it's a crosswalk. It's kind of like the Surgeon General's report, where it gives you ideas and suggestions in all of these areas of change related to workforce. Next slide. Sometimes I think pictures are worth 1,000 words. These are just some of our efforts where staff have, supported. I mentioned the ducks at Halloween, and that leadership team dressed up like ducks and hunters. Spirit days are a big thing that we do regularly. So just a few of those images from the organization. And I know I threw out a lot of different things we had done. I'm happy to share any of those materials or talk with anybody if there was something I mentioned that you have specific interest in. And thank you.
Thank you all so much. That was a wonderful presentation. Looks like we don't have any questions right now in the Q&A. If any folks do have some last minute questions we could get to, feel free to drop them in the Q&A now. If not, when you leave or when the session ends, you're going to be redirected. So just a reminder that we'd really appreciate it for you to take our quick 2 to 3 minute survey. I'm also going to drop the link to session 3, which is taking place on August 15th. And thank you once again to all of our presenters. It's been really, truly wonderful, and have a lovely rest of your day, everyone.